You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure, when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions, present your toughest ICU cases, collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, ladies and gentlemen. I'm Manu Malbrin, and it's my real pleasure to be your host together with Wickham for this fantastic webinar on an update on pulmonary embolism management and treatment, what every clinician should know in 2026. So I'm Manu Malbrin from Belgium. I'm a professor of critical care research at the first department of anesthesiology intensive therapy at the Medical University of Lublin. As that, I am the president of the International Fluid Academy, your co-host today, together with Wickham. Now, why are we here today? Why this topic matters? Because pulmonary embolism is a persistent clinical challenge, is a leading cause of preventable in-hospital mortality, and it's highly heterogeneous when it comes to presentation. Diagnostic delay remains very common, and management decisions are time critical. So it's about the right decision at the right time for the right patient. Now, what has changed in recent years is that we now have this multi-society guideline published in circulation just a few weeks ago, with a shift toward a structured risk stratification from low, middle, high risk patients, early discharge for the low risk ones, and escalation pathways. There's also the emergence of pulmonary embolism response teams, and I would say rapid response teams. So it's no longer managed in isolation, it's team-based care. Now, what we aim to achieve today is to understand modern pulmonary embolism management pathways, to define the role and maybe also the limits of point-of-care ultrasound, and identify those patients who need escalation in management and treatment. Now, just to warm up a little bit, I have prepared a voting. I will show the QR code. So if you're at a computer, you can pick your smartphone, scan the code. Otherwise, you can go to menti.com in any browser, Firefox, Safari, Edge, Chrome, the one you prefer. Go to menti.com and enter the code 43159491. Okay, so I see already 23 of you joined. We are 275 healthcare providers from all over the globe. And let us tell us what is your basic specialty. Is it anesthesia, emergency medicine, surgery, cardiology, maybe pneumology, because at the end of the day, it's about pulmonary embolism. So I see it's a mixture. And we have some ICU doctors, anesthesia, internal medicine, and emergency physicians. Now, next question is, are you or were you aware of the new 2026 pulmonary embolism guidelines published in circulation? And give us your honest feedback. Maybe you just downloaded the PDF before this webinar and you're working through the elaborate document. So I guess some of you have not heard. So I think today is a fantastic opportunity to get more insights. Now, another question would be, have you implemented a rapid or a response team at least? It would even be better if it's a pulmonary embolism rapid response team, like we know for sepsis management and treatment. And I see here the majority of you have not yet implemented, but may be thinking about doing so in the future. Now, the second lecture will be on point-of-care ultrasound and how we could use it in patients with PE or suspected PE. And just to grab your experience, if you have been using it, it looks like the majority have been using point-of-care ultrasound. Give us a quick vote. I see 51 of you are online. Okay. Thank you for the feedback and the interaction. Now, this is the outline for today's webinar. So after this introduction, I will hand over to Professor Amr El-Husseini, who will tell us about the guidelines and the management, and then Dr. Ashraf Al-Tayyar will tell us about point-of-care ultrasound, and at the end we'll have a discussion. Unfortunately, Professor Chiara Roba could not join us today due to urgent family business. So it's my pleasure to introduce the two speakers. Professor Amr El-Husseini from USA, who is Professor Medical Director and is President of the World Institute of Critical Care and Emergency Medicine, or co-host together with the Fluid Academy. He will tell us everything about risk stratification to advanced management. And then the next lecture will be given by Dr. Ashraf Al-Tayyar from UK. He's an acute medicine consultant at Kingsmill Hospital in Sherwood Forest in the UK, and he will tell us everything on the role of point-of-care ultrasound in pulmonary embolism. Having said that, I hand over to Professor Amr El-Husseini for the first lecture.
Thank you so much for this nice introduction. And today I'm going to talk to you about a very important subject that all physicians need to understand its importance and how to early diagnose and precisely manage this life-threatening disease that we can actually improve our patient outcome and decrease the mortality if we treat them appropriately. So this is the 2026 guidelines for evaluation and the management of acute pulmonary embolism in adults that was published 2 months ago by the American Heart Association and the American College of Cardiology in the Circulation Journal. And I'm going to focus on evaluation and diagnosis. Then we'll talk a little bit about acute management, how to monitor our patients, and also how to treat the long-term complication and expect them. Then we'll give you the guides, the take-home messages to precisely and appropriately treat this patient. Let's focus first on evaluation and diagnosis. And one of the most important 2026 updated guidelines is the risk stratification and classification of pulmonary embolism patients. So in 2011, we have the American Heart Association classification. They categorize pulmonary embolism into 3 classes: low, submassive, and massive. And this submassive was a little bit tricky, and it lacked precision and decision-making, particularly in patients with normotensive shock. In 2019, the European Society of Cardiology, they increased this categorization into 4 categories: low, intermediate, high, and high. This taxonomy, this nomenclature is very important. And now I think one of the breakthroughs that we have in the 2026 AHA ACC guidelines is the new classification to A, B, C, D, and E that is associated with improvement of the precision medicine and the therapeutic intervention. So let us do this brainstorming now. What's AA is patients who are clinically stable, they are subclinical or asymptomatic. Patient came in with abdominal pain, end up by having a CT, then they discovered that he has an embolus in his pulmonary artery incidentally. So these patients are hemodynamically stable, they are asymptomatic, they have very low risk of complication. So you can very safely treat these patients at outpatient basis with oral anticoagulant. What is category B? Category B is patient who is asymptomatic but have low clinical severity scores. They are not very old, above 80 years of age. They don't have congestive heart failure. They don't have malignancy. They don't have a family history of past history of pulmonary embolism. So this patient with low clinical severity scores, they can have brief hospital admission, start on low molecular weight heparin, then transition to oral anticoagulant, usually DUAC, the direct oral anticoagulation, then sent home in a couple of days. So what about C? So we are moving from the light green, dark green, yellow to orange to red. So this means that you need to read this color language. If we are moving from the less complex to the high complex category, this means that we are need to be more vigilant. So in patients with category C, these patients are symptomatic, but also they have elevated clinical severity score. This patient need to be admitted to the hospital. They need to be treated and monitored carefully, because also these categories are very dynamic. They can decompensate. They can move from category C to category D or E. So you need to anticoagulate these patients with parenteral anticoagulation using low molecular weight heparin or unfractionated heparin. Then you transition them to oral anticoagulation. Then you need to keep them in the hospital for several days to follow up them to make sure that they are properly anticoagulated. Then patients with category D, these patients are very tricky because these patients, they might appear cardiopulmonary stable, but actually they are in failure. They are in incipient failure, especially with those with normotensive shock. And we'll talk about this concept of normotensive shock in a little bit. Then clearly patients with category E, they have cardiopulmonary failure. They are hypoxic, intubated. They might need ECMO. So these are the 60 patients in the ICU. Again, A, B, C, D, and E. This is a common language that all physicians, when they see or treat or deal with a patient with pulmonary embolism, they need to talk the same language. And there is sub-classification when it comes to B. B1 is subsegmental, B2 is non-subsegmental. Symptomatic patients with high severity score, the C category, they might have both abnormal right ventricle and high cardiac biomarker, so that's C3. If they have only either abnormal right ventricle or increased biomarker, that's C2. If both are normal, that's C1. Again, D stage, they might have normotensive shock. This shock could be transient hypotension. Then in cardiopulmonary failure or stage E, they are hypotensive, they are shocked, and if they have cardiac arrest, cardiopulmonary failure on mechanical ventilation, that's E2. If they are only having cardiac decompensation, they have E1. Then there is respiratory modifiers. So now we need to think fast and slow. Fast, we need to categorize our patient. We need to risk stratify this patient. We need to better triage this patient. Who are we going to treat as outpatient? Who needs just floor admission? Who needs a very close follow-up in the telemetry or ICU? And who may need advanced therapy? Again, all of the upcoming guidelines are based on level of evidence, and the classification is based on recommendations from green, which has the strongest recommendation, that's class 1, to the red, which is actually harm to induce. So the benefit is low and the harm is higher. And of course, this is based on the level of evidence from high quality to expert opinion. Let's talk a little bit about the hemodynamic assessment, especially in category D. This patient with incipient cardiopulmonary failure, they might have normotensive shock. Their blood pressure might be very tricky. They may keep the systolic blood pressure in a normal range on expense of isolated organ hypoperfusion. And you can detect this hypoperfusion by measuring the lactate level, either venous or arterial, doesn't matter. You see the lactate level is going up, the patient is oliguric, there is AKI with increased serum creatinine, or the cardiac index is low. Or even if the patient cerebral blood flow is low, patient is confused, lethargic, this means that there is vital organ hypoperfusion, despite that the patient looks hemodynamic is stable and the blood pressure looks good, because we have huge ability to compensate and to adapt. So the systemic vascular resistance is going up, the sympathetic tone is going up on expense of the organ hypoperfusion. And one of the index that is associated with the 28-day mortality is the shock index. If you can see the heart rate exceeding the systolic blood pressure, so this ratio is more than 1, this is a very good predictor, I think, for organ hypoperfusion. Okay, so let us focus now on the recommendation based on the risk stratification. For patient with category C, you need to do at least one of the cardiac biomarkers to risk stratify this patient. So if they have high BNP or high troponin level, so they might need better care, because this is associated with increased complication and mortality. And in patients with category C to E who are undergoing evaluation at acute care facility, you need to measure the serum lactate level, again, either venous or arterial, it's recommended. So here are the biomarker. What about the right ventricular imaging? They said all patients with category C to D, again, this recommendation is class 1. So they need right ventricular imaging, and echocardiogram actually is better than the CT scan, as you will see in the next presentation. So in patients with category A to C, you don't need to do quantification of the angiographic thrombus burden. So there is no benefit of that. Let's talk a little bit about the medication, the intervention. And we need to think loud here, and we need also to do some brainstorming and critical thinking, because education is not learning of facts, but training of mind to think. So let us see the suitability of outpatient treatment. So patients can be treated in the clinic if they are hemodynamically stable at low risk, if they are incidentally discovered or asymptomatic. So patient category A and B in clinic or in ED who came into the emergency room, outpatient treatment is a reasonable option compared with hospitalization if the 90-day adverse outcome is low. Okay, let's focus now on the thrombolytic therapy. Patients who are getting thrombolytic therapy, either systemic thrombolysis or catheter-directed lysis, they need to stay in the ICU because of increased risk of bleeding. Patients who are getting advanced therapy with mechanical thrombectomy, they don't usually need ICU admission if they are hemodynamically stable because they are not systemically anticoagulated. What about patient transfer to a higher level of care? Yes, you can transfer patients from category C3 to D to a higher level of care center if they are hemodynamically stable. Please don't transfer patients with a category E except you stabilize them first. Okay. One of the most importantly emphasized recommendation in this 2026 guidelines is the PERT, the Pulmonary Embolism Response Team. This is very important. If your hospital are dealing with patients with pulmonary embolism, and if you don't have a multidisciplinary PERT, Pulmonary Embolism Response Team, please go ahead and try to set up this team, because it's a class 1 recommendation that all patients with category C to E need to be managed with a multidisciplinary PERT team. And the PERT team should include pulmonologist, critical care physician, vascular medicine, vascular surgeon, radiology, interventional radiology, cardiology, hematology, oncology, emergency medicine, pharmacist, nursing, and of course, patient or family member. So please, this is very important, because this PERT or Pulmonary Embolism Response Team is associated with improving risk stratification, expediting initiation of treatment, and helping clinician in selecting the most appropriate advanced intervention. Let's talk a little bit about anticoagulation. So if there is no absolute contraindication for anticoagulation, all of our patients in the hospital with class C, D, and E should be anticoagulated. And if you are using a parenteral anticoagulation, it's very important to know that low molecular weight heparin is now recommended over unfractionated heparin. It's less intense monitoring, and it's actually has been associated with better utilization and outcome. And for the long-term oral anticoagulation, DUACs are recommended. The rule of thumb is low molecular weight heparin initially, then DUACs rather than vitamin K antagonist. In category C2 or higher, don't wait to get image. If there is high susceptibility or high index of suspicion of pulmonary embolism, go ahead and start anticoagulating the patient even before getting the final diagnosis based on image. What about obese patients? So if the patient is obese with BMI is more than 30, please treat with DUAC, okay? And also, if you are giving low molecular weight heparin, decrease the dose per kilogram because of increased risk of bleeding. What about patient with antiphospholipid syndrome? This is against the rule of thumb. So the rule of thumb is to give DUAC, not vitamin K antagonist, but patients with antiphospholipid syndrome, actually you need to treat them with vitamin K antagonist, not with DUAC. But if the patient has only one antibody positive, either anti-cartolipine antibody or beta-2 glycoprotein, you can treat with DUAC. What about patient with metastatic brain tumor? Try to limit the use of parenteral anticoagulant and use DUAC. In CKD patient, also DUAC is better than vitamin K antagonist. in stage 2 and 3 in early stages, but in advanced stage, stage 4 and 5, the use of apixaban is probably better than the vitamin K to reduce major bleeding risk. This is uncertain, so it's not known to give apixaban or vitamin K antagonist in patients with advanced CKD. What about pregnancy and breastfeeding? For pregnancy, please don't give oral anticoagulant, don't give DUAX or vitamin K antagonist. But for breastfeeding, you can give the vitamin K antagonist, but don't give DUAC for breastfeeding ladies because it's highly excreted. The direct oral anticoagulants are highly excreted in milk, and it can increase the bleeding risk of the infant. For patients with chronic liver disease, still class A, it's reasonable to use DUAC. Class B, it might be reasonable also to use DUAC, but class C, there's no recommendation to use DUAC or vitamin K antagonist. Hemodynamic therapy, so you need actually in category D2 and E2 to use vasopressors in a probe and to give fluid management if the preload is low or volume dependent. What about inhaled pulmonary vasodilator? There is a benefit of giving inhaled pulmonary vasodilator? Yes, in C2 to E, you can use inhaled but not systemic pulmonary vasodilator as it reduces the right ventricular afterload. What about sedation and ventilation? So, of course, you need to stabilize your patient. Sometimes they need ECMO. And if they need high-flow nasal cannula, please use heated high-flow nasal cannula rather than standard high-flow nasal cannula because it's associated with improvement of oxygenation. Try to avoid deep sedation. One of the most important things they emphasize on, it's associated with increased harm, is to keep your patient deeply sedated. Again, we talked about compensation, adaptive mechanism to keep our organ functioning. So knock down this adaptive mechanism by keeping the patient comatose is associated with harm. So please don't do that. What about the IVC filter? The main indication for IVC filter is if the patient is getting, recurrent or repeated pulmonary embolism on full anticoagulation, or if there is a contraindication for using anticoagulation. If you are using IVC filter, please use a retrievable IVC filter because you need to remove it once the risk factor is gone or once the treatment duration is gone. So also, it's better to have a structured follow-up program for this patient with IVC filter. And it's uncertain, actually, to use this filter for patients who are very sick with category D to E, who are getting systemic thrombolysis, catheter-directed therapy, mechanical thrombectomy, or surgical embolectomy. And actually, in patients who are therapeutically anticoagulated, routine IVC filter placement should not be performed. So if the patient can be anticoagulated, if there is no recurrent pulmonary embolism on fully anticoagulation, don't place any IVC filter. Let's talk a little bit about advanced therapies, including systemic thrombolysis or catheter-directed therapy, which is a local, thrombolysis in the in the pulmonary artery, mechanical thrombectomy, and surgical embolectomy. It's reasonable to do it in category E1, and it's only considered in category D1 or 2. And for category C3 and E2, patients who have evidence of free-floating right atrium or right ventricular clot in transit, utilization of advanced therapy over anticoagulation alone is reasonable. But in C2 and D2, it's uncertain. Again, in category E1, patients with advanced therapy, you need to anticoagulate them. So you don't only do mechanical thrombectomy or surgical embolectomy or to use thrombolytic therapy, either systemic or catheter-directed thrombolysis. You need also to anticoagulate them. It's reasonable. And also in D1 and 2, it could be considered, but it's unclear for C2 and C3. How to monitor our patients. So you already know how to categorize them, then how to treat them acutely with anticoagulation. Then what about the post-acute care setting? So you need to see them, you are sending them to to home, then you need to see them in a week. And this is very important to address barriers to anticoagulation, to educate the patient, to ensure adherence to medication, and to detect bleeding risk. Then you need to see them again, evaluate them in 3 months. And by that time, you need to discuss the duration of anticoagulation. You need also to follow up them for at least for a year. And in each single visit, and all of these class of recommendation is one. In each single visit, you need to address the symptoms and signs of chronic thromboembolic pulmonary disease, including functional limitation, dyspnea, or other respiratory symptoms. If the patient remain anticoagulated into extended phase, 3 to 6 months at least, periodic assessment of risk and the benefit of continued anticoagulation is recommended. And depression and anxiety is common in these patients, so it's better to have a questionnaire and to do a survey and to check for symptoms and signs of depression and anxiety. And actually, in complex patients, C, D, and E, it's better to have a specialized BE clinic. What about doing the workup for thrombophilia and hypercoagulability state? So all patient class 1 recommendation is to do a thorough history, physical examination, age-appropriate cancer screen. On the age-appropriate cancer screen, you don't need to screen for all kind of cancer, should be obtained to diagnose undetected cancer. In patients without major reversible risk factor, who have a family history of pulmonary embolism or DVT, and the younger patient less than 55, it might be reasonable to perform genetic testing and also to do workup for secondary thrombophilia or hypercoagulability state. So routine imaging with PET CT or CT scan is not recommended to diagnose undetected cancer. What about ladies in childbearing period? You need to encourage them to have contraception to avoid further pregnancy, because pregnancy would increase the risk of recurrent DVT. But please try to avoid using of estrogen-containing oral contraceptive pills. Probably you need to use IUDs or a local barrier method for contraception. What about activity? One of the most commonly asked question about PE is the activity. So we always encourage early ambulation, early activity, physical therapy, and avoid bed rest. You can advise to use compression stocking if the patient has long-term travel, more than 5 hours for DVT prophylaxis. And if the patient is not anticoagulated and want to travel for long-term travel, actually you can give one-time prophylactic dose of either oral anticoagulant or low molecular weight heparin right before the long-term travel. For patients recovering from acute PE in category C2 to E, try to avoid long-term travel, try to restrict long-term travel for almost a month. What about the duration of therapy in patients without major reversible risk factor? Continuing anticoagulation beyond 3 to 6 months into extended treatment phase is beneficial to prevent recurrent thromboembolic disease. If the patient has a major reversible risk factor, say, patient was pregnant, or patient was in a long-term flight, or post-operative patient, or patient had a resected cancer, stop anticoagulation at end of initial treatment phase 3 to 6 months is recommended. So don't give extended anticoagulation. Complication, very important to look for the symptoms and signs of chronic thromboembolic pulmonary disease, chronic thromboembolic pulmonary hypertension, and residual vascular obstruction. So now I think in the future, we are getting better and better. Despite that, maybe our confidence is going down. But I think with more and more evidence, more research, better quality studies, eventually our confidence how to treat this patient, how to risk stratify them would be better. Again, it wouldn't go back to the highest level of confidence that you used to have, when we have very limited language and very limited knowledge. This is what we call Dunning and Kruger effect. Let's focus now. We are by the end of this lecture, and I give you, I flood you with a lot of information. Let's focus on the most important, pertinent follow-up and management criteria. You need to remember the classification A, B, C, D, and E categories of pulmonary embolism. This is the common language. When you call somebody, from the ER, you need to say this is pulmonary embolism, class C or D or E, and also have to be vigilant for the interchange and the overlap between these categories, because each category has its own decision making based on the long-term and short-term outcome. So in category A, patient who is asymptomatic, you can treat them at home with either with low molecular weight heparin or with oral anticoagulant, usually DUAC. In category B, with low clinical severity score, they can be treated briefly in the hospital, then transition to home on oral anticoagulant, usually DUAC. In patient class C, D, and E, these are sick patients that need to stay in the hospital. Again, you need to risk stratify this patient for the duration of therapy, and of course, to consider advanced therapy for category E patient. BERT is very important. You need to structure, you need to set up a BERT team in your hospital if you don't have one. And advanced therapy, systemic thrombolysis, catheter-directed lysis, mechanical thrombectomy, surgical embolectomy is reasonable only in category E and can be done, but the benefit doesn't really overweight the risk in D1 and 2 could be considered, but it's reasonable in advanced stage, which is E1. The rule of thumb is low molecular weight heparin is a hero. It's better than unfractionated and less complex in dealing with compared to unfractionated heparin. Exception, so the rule of thumb also is DUAC, rather than vitamin K antagonist. Exception is antiphospholipid syndrome. You need to treat antiphospholipid syndrome patient with vitamin K antagonist, warfarin or Coumadin. Advanced CKD patient, it's not very clear that apixaban is better than vitamin K antagonist. A patient with advanced liver failure, class C child classification. Breastfeeding, don't give DUAC to a breastfeeding lady. So DUAC is in every other problem is better than vitamin K antagonist. In patient with first acute BE without a major reversible risk factor, and in those with persistent risk factor, continuation of anticoagulation beyond the initial treatment phase of 3 to 6 months into extended phase is recommended. Patient should be asked about pulmonary embolism-related symptoms and symptoms of chronic thromboembolic pulmonary disease in each single visit for a whole year. Try to rule out any dyspnea, functional limitation, or disability. So I think that's very, very important to categorize and to treat our patient with pulmonary embolism based on these new guidelines. So actually, I think now we are more confident how to treat these patients. In essence, the American Heart Association, American College of Cardiology 2026 updated the guidelines, reframed the pulmonary embolism classification and the treatment. They classify disposition, rationalize escalation of care, strengthen the anticoagulation strategy, and demand long-term surveillance. So now the message is, I think, straightforward: classify carefully, treat proportionally, escalate deliberately, and never abandon follow-up. With that, I'm very happy also to acknowledge and to recognize Professor Heba Asal contribution in our respiratory critical care board. She actually inspired me to do this talk, and we hope the best for her. And with that, I'm very glad to receive any question, and hopefully we'll be able to answer it. Thank you.
Thank you so much, Amr. I see a lot of questions. We will take them after the next presentation on the role for point-of-care ultrasound. So let's move on with the next talk, and we'll have the questions at the end.
I think we can take one or two questions until Ashraf will be able to share his screen, if you don't mind.
Yes, sure. There are many questions. I would say, okay, if you have difficult cases like a septic case with infection, ARDS, coagulopathy, ischemic heart disease, and this patient is also found having a thrombus in the left ventricle. So these difficult cases where you have coagulopathy and bleeding, what would be the optimal management?
That's a very challenging question, but I think it's risk stratification again. It's a risk-benefit ratio. Most likely, most of these cases would be benefiting from using anticoagulation. Pulmonary embolism categorization, if it is category C, D, or E, it's potentially a lethal disease that need to be addressed. If there is no absolute contraindication, on top of treating, the ARDS by all measures, we need to fully anticoagulate these patients. Again, also with the new technology, using advanced therapy, you can do mechanical thrombectomy or surgical embolectomy without using thrombolytic therapy with lower risk of bleeding.
Okay, thank you, Amrus, with finding the risk-benefit balance. I see Ashraf's presentation is ready, so please, Ashraf, the floor is yours.
Yeah, thank you very much, Prof. Manu, again. Hopefully you hear me very well.
Perfect.
Let me start presenting this patient who presented to our ITU call before, which is 25-year-old female known to have sickle cell disease, admitted to the floor with a painful crisis of sickle cell disease. And then all of a sudden, she became very short of breath, obtunded, desaturating, presented with low blood pressure, 100/40. Her lactate was very high, and she was also presenting with frank shock. Echo should be done as part of management of any hemodynamically unstable patients, and also patients with respiratory failure. As we all know, and Prof. Amr Al-Husseini highlighted many of the important things about pulmonary embolism, we know that the pulmonary embolism is very fatal. In 10% of patients, they die in 30 days of presentation. And the most common reason for them to die is actually because of the impact on the right side of the heart. So we have to see and evaluate the right side of the heart with something that can give the full details that we need to know about the impact of the thrombus in the pulmonary circulation on the right heart. And actually, what we do, whatever the guidelines you go with, since very early, that we go with the clinical probability, and then we ask for the dimer, and then we need to confirm. And to confirm, you need to see the thrombus, if possible, and to see the impact of the thrombus on the right side of the heart, and to see the impact on the hemodynamics of the patients. But what can you do if you have patient? We know that the CTPA is the gold standard of the confirming presence of pulmonary embolism. But what can we do if we have patient who is shocked and or they are in acute respiratory failure? Moving them to CT is going to be very, very risky and even potential to complicate them. Then the point of care ultrasound might be a very good alternative to see the thrombus. Can we see the thrombus with the use of bedside echocardiography? The answer is clearly yes, sometimes. Not in all cases, but sometimes. You can see this thrombus, as you see here, in the RVOT. You can see it extending to the main pulmonary artery trunk on one of the pulmonary arteries. You can see it in the right atrium very visually. You can see it. You can see it in the IVC or the superior vena cava. if you are using the transesophageal echo. And again, respecting the clinical scenario and seeing with the clinical scenario of high clinical probability of pulmonary embolism, when you see the pulmonary embolus or the thrombus in the in right atrium, right ventricle, a clot in transit is considered to be enough to point to pulmonary embolism to be the reason for the clinical scenario that you have. I have a glitch here. To say that when you see the thrombus in the clinical scenario, then the diagnosis of pulmonary embolism is actually very obvious. If I have high clinical probability, then I saw the thrombus, then the point of care ultrasound is very helpful. You can see this thrombus also in the common femoral vein, in one of the femoral vein. So seeing the thrombus, respecting the clinical scenario that fits what you are seeing with a high D-dimer, this is pulmonary embolism. The second very important rule, fundamental rule for point of care ultrasound or echocardiography at bedside is to see the effect of the thrombus on the right heart. As we know from the evidence that around 53% of patients, more than 50%, who have pulmonary embolism, they have major effect to their RV. They have injury to the RV. And as we know from the physiology, that to have a significant pulmonary hypertension due to pulmonary embolism, the patient has to have a thrombus that occlude more than 70% of the caliber of the pulmonary artery or the branch of pulmonary arteries. But this can happen also even if the thrombus is not that big, if there is associated hypoxia, acidosis, hypercapnia. And then when you have this, the pulmonary artery pressure will increase significantly, and then the afterload will be significantly increased. This causes RV dilation and RV failure. Assessment of the right ventricle with echocardiography is very important, and it's considered to be dynamic when it's compared to the CT. You can see the right ventricle, and you can see if this right ventricle is dilated or not. Not only that, but also to see a lot of other details. And as we know from the point of care ultrasonography, for a practical tip here, that you should not overestimate the size of the RV when you do the bedside study. And this is one of the points that makes people saying that point of care ultrasound is an operator dependent. It's right and false at the same time. If you know how to do it and you estimate, not underestimate, not overestimate the size of the RV, then it's easy at the tip of the fingers of everyone working with point of care ultrasonography. We all know that when the RV is triangular in shape, it's normal. When it doesn't share in the apex formation, it's normal. When you don't see it, the trabeculae inside the right ventricle, these are the normal RV examination. Try not to be overestimating. If you see the RV dilating and you see the apex, as you see here, of the right ventricle is dipping down with the systole, we call this meconel. And when you see in the short axis parasternal view, the interventricular septum is flattening with every systole. This indicates interventricular septal dyskinesia due to pulmonary pressure, increase in pulmonary artery pressure. Two signs that are very specific and sensitive in pulmonary embolism. 60-60 sign is found to be very specific and very sensitive. You can use the focused RV view to see the tricuspid regurg, because with every significant RV dysfunction due to pulmonary embolism, the regurg through the tricuspid valve will be obvious, and you can use Bernoulli equation. Simply, bedside, use the jet across the tricuspid valve to measure the pressure across the tricuspid valve, and this can be used to measure the pulmonary artery pressure. I'm not saying very sophisticated things, but things that can be done easily bedside if you know how to do it. And you can see the notching, mid-systolic notching, and you can, in the pulmonary artery flow, on the RVOT flow, and you can see also and measure the pulmonary acceleration time. This is referred to, as I mentioned before, 60-60 sign. The pressure across the tricuspid valve is not that high, less than 60 millimeter of mercury, and the acceleration time is less than 60 milliseconds through the RVOT. These are very specific. And also, it's considered to be very specific for acute cor pulmonale to find the RV wall, free wall, not thickened yet, to compare it or to differentiate it from the chronic cor pulmonale. Things that the echo can give you in comparison to the CT. CT cannot give you these details. And at the same time, they are very important to know in any patient with pulmonary embolism to see if the RV is suffering or not suffering, and to what extent this suffering is there. Because, ladies and gentlemen, it's well known in the literature that the more the RV dilate, the independently risk factor is this RV dilation to predict the mortality. The more dilate, the more mortality are there. With the echo, you can help to differentiate, and this is one of the scenarios that we see every day in acute medicine and in ITU medicine as well, is to see patients who are known to have chronic cor pulmonale, but they present now with acute on top of cor pulmonale, acute on top of chronic, because of pulmonary embolism. How can you differentiate those type of patients? Difficult, yes, but then it can be, to more extent, be clarified using the bedside echocardiography. One of the tricky questions that everyone working in acute care settings has to keep in mind to answer them is, this patient with pulmonary embolism are affected hemodynamically or not? Because not every, as you saw from the classification, from A through the E, they are not all having hemodynamic instability. And the definition of hemodynamic instability is very tricky, by the way. It's not only the blood pressure. We heard of normotensive shock. What's this? If the blood pressure is normal, how they can be shocked? Yes, that the use of lactate to define the shock, use of delta bicarb and delta BCO2, use of troponin to see how much strain was on the RV are all respected. But what if you can see the hemodynamics using the bedside echocardiography to define hemodynamically instability for those who deemed or seemed to be clinically stable, or even by CT they are stable, but by echo they are unstable. One of the most important significant predictors of bad outcome was found in everywhere, that hemodynamic instability with pulmonary embolism is linked to bad outcome. And we saw here, as Professor Amr Al-Husseini showed us, the new classifications. They mentioned something about normotensive shock. How can I know this? Is it only with lactate? And what can I do if the lactate is not increased? But what I see with echo, when I see the RV dilated, when I see that the interventricular septum is flattened significantly and the left ventricle is affected significantly, in relaxation to receive the good amount of blood to eject it in systole, these are all impacted or affected in pulmonary embolism patients. CT, ladies and gentlemen, can tell you something about the RV size in comparison to the left side. It can tell you that the septum is shifted to one side, but doesn't tell you anything about the function of the right ventricle and the function of hemodynamics. Are they maintained or not? These are very crucial things that you have to answer them. And actually, fortunately, in majority of patients, you can measure the RV cardiac output. People, they know more about the left ventricle cardiac output. When we are able to measure the VTI, the velocity time integral, in the left ventricle outlet tract. We can do the same for the right ventricle outlet tract when we have a modified parasternal short axis view and we open the pulmonary, the RV outlet tract, and we fire the Doppler just proximal to the pulmonary valve, and we can measure the VTI through the cardiac output, the stroke volume, the amount of the blood ejected from the right ventricle. This is the end result of any hemodynamics, actually. You know, even if your patient is still maintaining his or her blood pressure, but their cardiac index of the right ventricle is less than 2.5, the definition of cardiogenic shock, they are shocked, even if they are clinically looking stable, even if they are with a normal lactate. And we see cryptic shock. Sometimes we define it as a normal blood pressure, normal lactate, but patients are shocked. Not only that, but also when you measure the TAPSE and you know how much the systolic function of the right ventricle is impaired or not impaired at all, even if you have the classic features of RV dilation or RV injury. Not only that, but also it's possible with bedside echo to see how is the behavior of the left ventricle in this hemodynamic, very risky patients. Is the left ventricle maintaining the cardiac output or not? Some people, they believe when they see that the left ventricle D-shaped, that the RV is hyperdynamic. Left ventricle hyperdynamic. It's not hyperdynamic. The ejection fraction might be looked overestimated, but the cardiac output with the septal shift toward the left ventricle will impair the cardiac output, as you see here. So the cardiac output of the left ventricle in severe pulmonary embolism impaired, and you can here define again the shock in a different way, in an echocardiographic definition way. If you have a VTI less than 15 centimeter per beat, this is considered to be very low VTI, especially if you are dealing with the stress when the left ventricle has to eject more blood, actually. Not only that, but also a common mistake for those who like and love to use the fluid responsiveness techniques or tools, pulse pressure variation, stroke volume variation, VTI variation, peak velocity variation. They are all present here in the cases of severe pulmonary embolism. And it seems that with using these tools that you have to give fluid to pulmonary embolism patients who are in shock. And this is a common mistake, unfortunately, because what you see as a fluid responsiveness indicator are not because of the fluid response, not because of hypovolemia, but because of RV dysfunction. And this was tested in several literature. In the literature, you find a lot of evidence on this, that you see a variation, not because of the volume lack, but because of RV dysfunction. And giving fluid for any patients with pulmonary embolism, and they have septal shift to the left ventricle, and they have significant RV dysfunction, and they have systemic venous congestion, giving fluid here is very detrimental, actually. This lady was given thrombolysis and avoided to give fluid. We used, and we have to use, norepinephrine transiently to improve the hemodynamics till you give the thrombolysis, and she was saved. Ladies and gentlemen, there are a lot of different and difficult scenarios we are facing in ITU and we face in acute medicine, like this young patient who was in COVID era and presented with ERDS, required to be intubated, and while she was in prone position, she suddenly deteriorated hemodynamically. She was on 100% FiO2, high PEEP, and very high dose of norepinephrine to maintain roughly the blood pressure. What was the reason for this? Can you move such kind of patients to the CT? Can you do D-dimer for somebody who is already in ERDS, COVID, and a lot of infections? But when you do the bedside echo, you might be very lucky to see a thrombus, as we see here, the thrombus sitting in the IVC. And when you see a flattening of the septum, of the interventricular septum, and a huge dilation of the RV, then what you saw suddenly can be explained by pulmonary embolism, and you can thrombolize such a kind of patients. It's very obvious sometimes the benefit of the using the bedside echo in diagnosing and managing those type of patients, even if they have alternative reasons to think of something else, not the pulmonary embolism. Like in here, significant effusion with a consolidation collapse of the base, the right lower loop of the lung. But if you see here, you can see that the interventricular septum is grossly moved to the left side, flattened. The IVC is very distended than it was pulmonary embolism. Can the echo be deceiving? Yes. We see this patient with a lot of lung changes, wet lung, consolidation, very dirty looking pleura, and then everyone around this patient thought that this is ERDS. The D-dimer was high. There is explanation for this. The score is highest. She is in very high flow of oxygen. The alternative diagnosis was here. But look at the RV. It's not grossly dilated. And the septum is not shifting at all. And the IVC is totally small and collapsing. So everything by echo is toward not a pulmonary embolism at all. But we said, let's do the CT to rule out pulmonary embolism because somebody else suspected pulmonary embolism. And it was actually a saddle-shaped pulmonary embolus. So it can be deceiving. Listen, gentlemen, the guidelines in the literature are very straightforward, indicating a pivotal rule and fundamental rule for transthoracic echo in diagnosing the pulmonary embolism and the effect of embolus on the right side heart circulation and the left side as well. Very clear in the guidelines from the European Society of Intensive Care, of Cardiology, and many other societies. When you see people who are interested with a lot of research in the point of care ultrasound, you see this message is very clear. We couldn't see, this is a meta-analysis, one of the big meta-analyses in the literature, and there are a lot of this, show the specificity of more than 80%, and this is a good number, by the way. Though it's low sensitive, you can rely on to rule in, not to rule out pulmonary embolism. They are very helpful in unstable patients. Something and messages that we couldn't see in the latest EHA ACC 2026 guidelines, because they mentioned that this is in no benefit group, the COR3, that a transthoracic echo is not recommended to confirm or to refute the diagnosis of pulmonary embolism. Something that I personally couldn't understand. I couldn't understand despite the clear definition, the clear mention, of the normotensive shock to point toward how can I diagnose in another way or in a subset of patients who present with a normotension while they are in shock, relying on equally a subjective finding of things that can be negative, while you can see with your eyes and you can measure a lot using the transthoracic and transesophageal echo sometimes. The only clear directions from the latest guideline was when you diagnosed pulmonary embolism. You have a patient, you suspected, you confirmed the diagnosis, then use the echo. We're trying to say that echo should be used when you are about to think of pulmonary embolism as an add to the CT, because a lot of advantages are there, overweighing sometimes the value of the CTPA in seeing the impact of pulmonary embolus dynamic finding of the impact of pulmonary embolus on the right heart circulation. This is very clear. Look at the guideline when it mentioned the use of Doppler to diagnose. After you diagnosed the pulmonary embolus, they mentioned tissue Doppler, while we don't use the tissue Doppler in pulmonary embolism. I want to say, ladies and gentlemen, at the end of this presentation, that I believe, and there are a lot of evidence to support that the point of care ultrasonography at bedside is very mandatory, very needed, essential, helpful to reach the diagnosis, especially in the critical situations when you cannot do the CT. And it can help you to decide in the cases of query shocked or not. When you see the thrombus, there is no other evidence needed that this is pulmonary embolism. When you see the impact of the thrombus on the right side of the heart, the best to tell you that the heart is suffering is the echo. And the hemodynamic understanding cannot be done as it can be done by using the bedside point of care ultrasound, and of course, helping you to decide which way you go with. Thank you very much.
Thank you so much, Ashraf, for this excellent lecture. There is a question, and I think is intriguing. So in the past, when we perform ultrasound, we can see whether there is RV failure or not, and whether the patient was stable or unstable. It was very easy. You did the ultrasound, you saw RV dysfunction, and then you could escalate on the treatment. Isn't this new classification A, B, C, D, E making things more complicated?
For me, yeah, as I mentioned, it's not making it complicated, but it doesn't tell a lot when it comes to how can I define these subclassifications. So when you say, as I mentioned, a normotensive shock, how can I define this normotensive shock? This is, by the way, the most tricky and critical part of the pulmonary embolism. When you have pulmonary embolus diagnosed by CTPA and you have shock, frank shock, there is no need to do anything. But as I mentioned, I presented a case who was the CTPA definitely, I'm going to say, contraindicated to do it. How can you move somebody who is in acute respiratory failure and in shock to CT angio, to CT suite? This is technically very difficult and risk patients to die. But when you see in these scenarios, it's a straightforward, and the echo knows and tell you what to do. For those who are having RV dilation in a scenario of pulmonary embolus, and they are diagnosed by CTPA, and the troponin is increased, RV strain is significant, the ProBNP is increased, the right atrium is significantly dilated. But then, we see these cases, you do the lactate is normal or transiently high, and the blood pressure is literally normal. When you measure the right side cardiac output, and this can be done, by the way, easily bedside, you define if your patient is shocked or not, even if the other parameters does not point. And in yesteryears, Manu, if you remember, we used to see some controversy to thrombolyze submassive pulmonary embolism patients. And people, they relied on a fact that open artery is better than occluded artery at the end of the day. If you give thrombolysis, for those who are not at very high risk to bleed, then when you open the pulmonary artery, it's better than you keep it closed. It might take 2 weeks, 3 weeks, months to reperfuse again spontaneously with the help of anticoagulant. But what if you can achieve this today? This makes difference. And again, by using the bedside echo, the problem is that people actually still underestimating, though they are working in acute care settings, they are underestimating the value of point of care ultrasonography in such kind of cases.
I'm looking at the time and I'm asking Amr, normally we have time till...
We have maybe time for a couple of questions, maybe 5 minutes.
Yeah, 5 minutes. I have a question for both of you. If you had to choose, and you have to be honest, if you have to choose one intervention that has most improved the outcomes of pulmonary embolism in the last, let's say, 10 years, and then with the new guidelines, would it be better imaging, better anticoagulation? Would it be the response teams, the PERT, or POCUS? Which one and why?
That's a tough one. I will let Dr. Ashraf to try to do some brainstorming.
Yeah, I actually go with all of this. You have to give me option, all of them, all of the above, all of the above. It's a puzzles, and you need at the end of the day to put the puzzles together to reach a decision in sake of saving this patient's life, because the pulmonary embolism is really deadly. And that's why since a couple of years now, we started to hear of PERT. And PERT idea, when it came to the practical field, was to bring people together as soon as they can to decide. And blind spots in this decision-making puzzles or algorithm can make a lot of confusion, and it can obscure the decision.
I was assuming you were going to say POCUS changed most of it. I think it's the modern stethoscope, and it gives us so much information. It gives us dynamic information. We can reassess after the treatment, and it's really a bedside tool. Amr, do you want to?
Yeah, just the way that we structure our question, we are not competing with different diagnostics or different treatments. They are all adds up to our patient care. They are all complementary to each other. No single intervention is better than the other. They are all helping. So the way that we think about our patient, we need to do everything possible to improve their outcome because it's potentially a lethal disease.
I see an interesting pathophysiological question, and the question is for Dr. Ashraf, can there be a difference between the RV and LV ejection fraction? I would say yes, but can there be a difference between the RV and LV cardiac output?
This is a very good question. And physiologically, the cardiac output of the right side should be equal to the cardiac output of the left side, definitely, because the left ventricle relies on the right ventricle to get the blood. And there are numerical small change between the RV and left ventricle, of course. The RV is slightly less in the cardiac output compared to the left ventricle. But both should have the normal cardiac output to maintain the other's one cardiac output. This is very, very fundamental to know. And we forget this. And this is the reason behind why we underestimate the right ventricle importance. Everyone in hemodynamic instability looks and focuses on the LV, while the right ventricle is essential for the left ventricle function. The common cause of RV to fail is LV failure. And common reason for LV to fail is RV failure. This has to be in mind.
Okay, maybe for Amr, a last question. There are many more questions, but we won't have the time to go over them. We've captured all the questions, and I think, Amr, we can provide the answers and then reach out to the delegates with the answers. So one final question on the scoring. We have this well score. We can have a rule out pulmonary embolism score. We have D-dimers, and we have the PASI score, or the simplified PASI. Question would be, when to use what? Do we use them interchangeably or sequentially?
That's very good question. Actually, I covered almost all aspects in the guidelines, but I try to avoid this clinical scoring system because they are complicated and they need dedicated lecture. But the basic score, I think they emphasize on its use. It's 11 elements, including clinical, biomarker, and the radiologic, evidence.
And the heart
So,
rate and the systolic blood pressure, right? To
right.
calculate the shock.
Yeah, the shock index and other, the need for, the hypoxia, the need for, oxygen therapy, patient age, a history of cancer, family history, past medical history of thromboembolism, COPD, congestive heart failure. There are 11 elements, clinical and biomarkers. So there is different algorithm and there is different simulators and calculators that you can do some math and do the clinical severity score. I think they are all good, but maybe BASI was emphasized more in the recent guidelines to use. Again, you need to do this not once, but you need to do it periodically because the criteria, the classification, the category of your patient is very dynamic. So maybe the basis score now is 65, maybe in an hour or two will be 100 or 110 or whatever. So it's very dynamic.
Okay, so I would say the first step would be to estimate the pretest probability. This is what we are talking about. So the well score could be used for that. And in those with a low risk, you could use the pulmonary embolism rule out criteria to rule it out without further testing. And then the other ones, they should get the D-dimer and then maybe decide on CT imaging if it's elevated. And then you can assess the severity. So I think they can be used sequentially. Okay, I think we're running out of time. This was a fantastic webinar, one in the series of collaboration between the International Fluid Academy and WICAM, and we will definitely have more of these webinars in the future. I saw at some point more than 450 delegates from all over the world, so I think it's a fantastic and it shows that there is a lot of interest, and we didn't even discuss fluids. Jesus, we totally forgot to discuss fluid management in RV failure, but that maybe is for another webinar. So I would like to give you the last words of wisdom, Amr, and maybe first Ashraf and Amr to close the webinar. Ashraf, please.
Thank you very much, Prof. Manu, for this very nice webinar. And I hope the clear message was there that from my side, a point of care ultrasound should be included in every guidelines for sake of patients, for sake of right decisions in the right time. Thank you very much.
Thank you so much, Manu and Ashraf. I would add that there is flexibility in patients management. This is what I like most for these guidelines. They don't tell you, they don't dictate exactly what you need. They give you a roadmap, and every single patient is different. You need to categorize your patient. You need to weigh the risk and the benefit for each treatment, and including the standard conventional therapies and the advanced therapies. So you need to tailor your treatments. There is no one size fits all. We have to personalize. We have to individualize and personalize our treatment and interventions based on the patient benefit and the risk. There is no single study or single test that is a gold standard. It's all, adds to others. Even negative POCUS, negative echocardiogram, doesn't rule out presence of PE. It's all about the clinical test probability. So it's very important to do this. Again, what we have discussed today is we are just scratching the surface. The field of the respiratory critical care specialty is huge. Every second counts, and it's very good opportunity to improve our patients' outcome based on the new literature. We have a 1-year online fellowship that is going to teach all of our fellows how to precisely and appropriately treat your sick patients with respiratory critical illness. So if you are interested, if you are welcome to our fellowship program. The door is still open. We are going to start the fellowship for this 1 year in June. So please feel free to use the promo code to get the 10%. I think there is a lot of information. Please stay in touch. Again, if you have any question regarding the pulmonary embolism or the respiratory critical care field, we are all here for you. Manu, myself, Ashraf will be happy to answer any question or address any inquiries in the future. Thank you so much.
Okay, with that, I close this fantastic webinar. I also would like to extend an invitation for everyone to join the Fluid Academy. It's free open access medical education. Sign up, become a fluid champion now, and start your path to become a center of excellence in fluid stewardship, and why not also pulmonary stewardship and sepsis stewardship and stewardship. And POCUS stewardship. Absolutely. Okay. Thank you for joining. Stay safe. Bye-bye. See you next time.
Thank you. Bye.